ongoing projects, ongoing projects and activities. So for today's session, we are met with imaging. Oh,
yeah, got it.
Oh no, it goes underneath.
Yeah.
Wow. Okay, that's unfortunate. Enter. No.
And you don't want to leave the meeting.
Okay, I will change it as soon as possible. Yes, so we are here with imaging experts and experts in health economics that are working towards bridging access, cost, and investment gaps.
You just have to click there.
The mouse kind of goes underneath the notification.
But that's fine, you can just click there.
Okay. Perfect. Okay.
Thanks.
Yeah, thanks. So this talk will shed light on the economic challenges and the growth opportunities in access in imaging technology in low middle income countries. Today we will have a total of 4 talks. Yep. So we would like to ask you to hold your questions until the end for the panel discussion, and also to make it as interactive as possible for the people online. Please write your questions into the chat, or otherwise during the panel discussion you can raise your hand and we can allow you to speak and you can unmute yourself. So without further ado, our first speaker is Somto Okoli, who is a third-year Bachelor of Medicine student at the University of Bristol. She is interested in public health and academic medicine, and came in touch with CAMRA through her supervisor, Shoda Deleke, who's also a long-standing member of CAMRA. So please, Somto, your floor is yours. Let me just open your site. Sorry, we're having some technical problems. Can you see it on Zoom?
On Zoom, yeah. Can you start the?
Yeah, just trying to.
Yeah, you have to.
No, this isn't the way. On the bottom.
You can grab that and put the screen sharing lower.
Wait, that's okay.
There you are.
Hi everyone, it's great to be here today. My name is Somto Okoli. I'm a third-year medical student at the University of Bristol, and today I'm here to talk about improving MRI access and improving MRI development in low to middle income countries. So MRI is a very useful imaging modality, and we all know some of its advantages, such as the better visualization of soft tissue compared to ultrasound, CT and X-ray, and the lack of radiation compared to X-ray and CT. Despite these advantages, there is an issue with the access to MRI in low and middle income countries. So today we'll be talking about some of the reasons behind that and some solutions to tackle this issue. So why is this important? Why am I here? Well, Africa has a fifth of the world's population with the least access to MRI. In the West African region, there's about 400 million at the moment, the population, but in around 2016, the population was 370 million, with only 84 units of MRI serving this region. So that fact really highlights the level of disparity we're talking about. And the scanner density in low to middle income countries is a lot less when we compare it to their high income country counterparts. Including this, we also know that there's an inter-country disparity. So in low to middle income countries, the more urbanized the region is, the more MRI scanners available. So the reason that this is so important is because low to middle income countries are undergoing what we call the epidemiological transition, or the double burden of disease. Essentially, they already have the public health issues of dealing with communicable diseases due to poor sanitation, poor diets, poor nutrition, but now the prevalence of non-communicable diseases has increased. And this is due to increased urbanization, so people are perhaps smoking more, they're drinking more, poor diets, more sedentary lifestyles. And it's important that these communities have the tools to actually manage and deal with these conditions properly. And MRI is just one aspect of that. So this session is called Health Economics. So it wouldn't be this session if I didn't mention some of the numbers involved. In low to middle income countries, about 40% of the healthcare spending is out of pocket and expensive. So there's an increased personal burden to actually pay for your healthcare yourself. And historically, we know that low to middle income countries allocate less of their GDP on healthcare. So around 5%, where in high income countries, this is around 12%. Previously, Camera decided to initiate a needs assessment survey. Essentially, they reached out to radiographers and radiologists, and they wanted to identify the 4 central priorities to improve MRI access. So they identified 4 things: availability and access. So what were the density of the MRI scanners available? Where were they located? Was it in public hospitals, private, teaching hospitals? And what was the dispersion of these MRI scanners? So were they in rural areas, urbanized areas? And also they wanted to know the field strength of the scanners available and if they were actually being utilized. Secondly, they wanted to find out about personnel training and education. So did the personnel have the capacity to utilize the MRI scanners? And if they did, could they interpret the scans properly? Also, was there any access to teaching and educational opportunities? Thirdly, research translation. So using MRI technology, were they able to drive and improve healthcare outcomes in their own communities? And could they also network with other individuals to further improve this? And finally, sustainable technology. So was MRI technology actually sustainable in these regions? From that, we identified some challenges, and through our own work, we also identified more challenges. One of these challenges includes donations from high-income countries. So around 20 donated equipment actually becomes and this is due to numerous reasons, such as the age of the machine. So depending on the age of the machine means that sometimes the low to middle income countries can't actually accept a donation despite the scanner being functional. Also, sometimes the parts given by machines were missing parts, and this was difficult to acquire in these countries. As we all know, MRI scanners have specific infrastructure requirements, which are challenging to implement and maintain in low to middle income countries. And one way around that was making sure that the parts that we were creating in these countries were fit to purpose for the location they were in. So slight alterations could be made, such as making more user-friendly MRI consoles or making low-cost data acquisition systems. We also suggested that AI could be a useful tool in these regions. So for instance, AI could not only support clinical diagnosis, but it could also enhance image quality. And we know that in low to middle income countries, most of their scanners are of the low field priority. Additionally, power supply is an issue in these countries. So often there's power outages or lack of internet. And because of this, it meant the data loss was occurring at a high level. And what we suggested is by creating a local means of backup, we could prevent data loss and actually assist radiographers in their work in these countries. Additionally, we also know that MRI machines use cryogenic liquids. These are expensive to maintain, store, and there are specific infrastructure requirements required for this. So we suggested that low-cost liquid nitrogen could be used, and also this was a better alternative as it had less requirements in terms of maintaining and storing this. Finally, in terms of magnets, so the magnets are arguably the most expensive part of an MRI machine. And we know that the better quality your MRI scanner is, the heavier it is due to the magnets involved. So one way around this was using permanent magnets, and we found that by switching from permanent magnets, we could allow more open configuration as shown in the images. And then we could also, it was a cheaper alternative. It still had better temperature stability than the original solenoid magnets used in MRI scanners. Touching on some of the social factors, so for instance, we found that there was a lack of training and educational programs available in these countries. And thankfully, organizations such as CAMRA are doing a lot of work to improve this, but this is still an issue. Additionally, there was other social factors such as distrust of new medical technology and a huge amount of healthcare literacy, which was making this an issue to actually developing MRI access in these countries. So just to summarize on some of the solutions I proposed, we want to make sure that the MRI components are locally made, but multi-purpose and durable. Using AI technology, we can actually make clinical diagnosis a lot easier in these countries. By developing portable MRIs, it will make it easier to reach rural areas, and also introducing more educational programs is a good step to improving MRI access in these countries. So just to finish what we've been doing, so to develop a comprehensive solution framework, we first started off with changing the current CMR reporting protocols. So we identified that this was an issue in low to middle income countries due to the lack of was streamline the process a little bit and make in healthy volunteers in North Nigeria, and we actually found that this was a good alternative for the current CMR protocols. So some take-home messages. MRI has the potential to become widely available in low to middle income countries. With the rapid expansion of technology, it will be long before this is possible, but we need to emphasize community engagement and co-creation to make this possible. Thank you.
Thank you very much for your time, Somto. Yes, so please ask questions at the end. I'll just prepare the next presentation again. Right.
You want me to introduce Lukas in the meantime?
Sure. Or I can introduce him.
Yeah.
Yes.
Okay.
So Lukas Winter is an MR researcher and developer at PTV Berlin, and he aims to make medical devices more available globally as the founder of open source imaging.org. And his talk is titled Open Source MRI from Device Development to Product. And as soon as I can get the presentation over. Yes.
Yeah, thank you very much for the introduction and for the invitation. So I'm really happy to talk here. I think the camera is fantastic, and looking forward if we can find ways to collaborate. So I'm working for a government institute, National Metrology Institute, and the title of my talk that was given to me is the open source MRI from device development to product. So I probably need to disappoint the organizers and who invited me, and probably also the audience, that just the second slide of my talk is already a disclosure that I have nothing to disclose. So there's no company that I'm working for, and there's no company money that I'm getting. Now I'm here standing and talking about product development. So I still have a little bit less than 20 minutes trying to make sense of my presence here for you, and I hope I can transmit a little bit the idea that we have. So the motivation is very simple, and so I think we're in a camera meeting, so camera also said it pretty nicely. So MRI remains largely inaccessible to clinicians, patients, researchers in low resource areas. such as Africa. And this is probably not surprising to any of us. This is happening in most fields in medical technology. And there are many reasons and challenges for that. Many of them have been said, so funding, donation-based system, brain drain, infrastructure, etc. And I'm not the expert to talk on this, and you will hear other experts giving you more details on that. But these challenges, we do observe them since many, many years. So for me, as a researcher, collecting the data that I get, seeing how things has been done in the past, I don't think this is the way to go, trying to solve this gap in accessibility. So we need to try to find different ways how to approach this problem. And one way that we are very much convinced about is actually an open source way. To basically work more collaboratively as a global community, develop open source tools, both software and hardware, and actually channeling all these resources then hopefully into products. So I'm always having the slides in the presentations just to make sure that we know what we're talking about. So what is open source? Open source is that if you have a piece of code or a piece of hardware design and you share it publicly, you basically have also an open source license associated with it. So basically you give away your freedoms, or in a different way, you grant the other person or any other person that gets this information freely, you grant this all freedoms that this person wants to have. So basically, I can study it, I can modify it, I can distribute it, but I can also sell it. So I can make products out of this piece of information that I get. And I think that's the very basic but very powerful concept. And just that it's clear what is meant by that. So the ability to sell products based on this information, this is possible. So when we look at how we do things at the moment, so we have our scientific community, and this is mostly scientific conference, and we have our innovations, can be code, can be hardware, we have our prototypes, we have some type of scientific or even clinical evaluation, we have our papers, these are the results we publish. Most of our funding comes from public sources, and then the part which deals then with products is a completely different story. So it's completely interconnected. There's a huge gap because you need to do much more, right? So you need to take care of safety, documentation. You need to have some quality management systems, etc., a production process, and so on. So there's a huge gap as we do things at the moment, and it's difficult to motivate. Now this right-hand side of this slide. Maybe I will just turn on my, maybe not. Use my mouse. Oh no, this will not work. Okay, no problem. So so it's more challenging, and I completely understand the arguments to motivate the industry or more private funding to actually solve our accessibility issues. But on our public funding side, so maybe we can do a little bit more that is happening here on this right side of the slide, and I will come to that later. But let's have a look at the science first and where we are at the moment. So we, and I say many groups and people engaged in this task to develop open source MRI systems. I would highlight one prominently because this is the group in Leiden, so the Leiden Medical Center, which brought together a low-field MR system that is largely consisting of some open source components. And this is the system that you can see here. My mouse is not working, okay, but you can see it in the slides, and it's a head and extremity system. The material cost is relatively moderate, so around 20,000 euros. It's part of the system, you can push it around, it's around 50 millitesla. And the nice thing about it, it's open source hardware and open source software mostly. And currently there are 3 such systems. There are more very similar systems. but you can see here there's 3 versions in the Netherlands, then Germany, and in Uganda. This is the one that we brought also last year. If you have been on the ESMRMB, this is the system from Leiden, which we packed in this van and then drove over the ferry to the ESMRMB. Was a huge success because there was a lot of interest. So it's very portable, it's very nice, and this was also, by the way, built your own open source scanner session. So their interest is there, the community is there. Then Tom and Wouter, which you can see in this photo on the right-hand side on the bottom, they went to Uganda to visit Jonas, and together they built another system over there. So it's also possible to do this in a relatively short time. So this was less than 2 weeks that the full system, including this image of the bell pepper, was made, which is possible. And then at such events, of course, there are others that are interested. So the whole thing spreads to other sites. And there's, for example, also Josh Harper and this image who's from Paraguay and who's currently also constructing such a scanner. So this is nice. This research aspect is having a look a little bit into the clinical domain, which is still yet to be evaluated. So locally it's of course booming, and we're excited about it to see what it can do, what it can't do. But there are some nice images. So you can see here some nice in vivo images covering the whole brain. And if you see some other work from other groups in the same at the same field strengths, that's actually pretty exciting to see what contrasts are already possible. So again, we're talking about something that is still not fully optimized, right? So this is quite exciting. So I'm or to put it in different words, it will have, or it has clinical value. Now we have this is the scientific part, and now we actually want to go the next step, because for our open source MRI, we actually need to get much closer to the clinic. So what we just started now is a bigger European project. There are 19 partners involved, and we will build several systems that will be a little bit optimized from this previous prototypes. It will be all open source. They will be fully characterized. After all, we are working for a metrology institute, and there are other metrology institutes involved, so we have to do these things, right? This is our job. Then we will compare it also in terms of imaging quality to other low-field systems, and to, of course, some testing out some more scientific endeavors to improve image quality and test some other things. But I think one thing that is probably one of the most exciting parts of this, or exciting, it depends who you ask. The researcher probably thinks the paper is exciting, but I think impact-wise, it's quite exciting that we will also prepare documentation according to medical device regulation. We will not be able to do all of it. It's a huge effort to do that. But we will do as much as we can. And this is also something that we will share openly to basically have some type of blueprints, right? So these blueprints don't exist. And so basically what we're trying to do is with this development is to get closer to a product, right? So to close this gap that I was talking about earlier. And in the consortium, there are some companies involved that are interested in some of these results. Of course, it's still on an open source basis. There are there's a metrology institute involved that just got accredited also as a notified body. Yeah, so they have an idea of regulatory issues. So it's quite exciting to see how we can combine this. Coming more to some things from the system. So there's of course a magnet. It's permanent magnet, and here you can see this version 1. This is the previous magnet, so the new one will be a little bit shorter. so that the head can get a little bit better in the isocenter. That you can see here, we started to do some first tests that it's actually constructible, so you can see some preliminary setups here, and you can see the small cubic magnets that are being used, cubic permanent magnets that are being used. Yeah, so this, sorry, I didn't mention that, but this is also a collaboration between PDB and Leiden for the magnet design. Then after the magnets, we have grading coils here. And I was also part of the consortium, which is called the wiring pass. So relatively simple, you just need to set up your parameters that you would like to have over the volume that you're interested in. Then you get the wiring pass, you get directly an STL file, you can use it in a CAD program, and then you get such a gradient coil former where you just 3D print it, and you add your wires, glue your wires in, and then you add it to your magnets, and you have a gradient set. So that's quite cool. And then the nice thing about open source, so it started as a MATLAB code, and now someone from the community saw it and converted directly in Python. So now there's a Python version, so everyone can use it. There are some amplifiers available. There's a gradient amplifier at 15 amps per channel. There's some power amplifier that is maybe a bit too powerful for most applications. So this is a kilowatt peak power. We're currently working on reducing that actually a little bit, less noisy and less cooling efforts, etc. But interestingly, also here, like slowly from industry side, there's some interest. So there's a company which is Physikalisch-Technische, and they or they make a RF amplifier design for the system that's at a bit lower power, and they actually started to open up their not completely, so they don't share everything so far. Maybe it will come at some point, but they are very much open or interested about this concept of open hardware. So this will be also a semi-open design. So that's quite cool. We have console hardware. Here is the core is a Red Pitaya, just relatively affordable, and an Okra 1 board that has the digital analog converters for the gradient amplifiers. And then there will be some other yard switch designs that will be also shared in the future. And the Red Pitaya is not open source, but again, it's an affordable software-defined radio. And there's an open source software code, and here we use Marcos, and you can see the GitHub link there and the paper if you're more interested. And also nice thing about it is it's PulseSec compatible, so you can do your pulse sequence programming in PulseSec and just use this console to play out the pulse sequences. And then some example of who's actually using this such a hardware or such a console for in vivo MR images, and this is some nice work from Valencia. And you can also find some nice posters in the poster session to get more information on that. For the software, we work together with Brainlink. So this is also an open source software. Will be cloud-based, but cloud-based means also that, of course, you can download it on any computer and run it without any internet connection. But I think the cloud's compatibility is something that we envision to be very powerful, because you can, through the software that controls the systems, you can actually connect people, which otherwise is a little bit more difficult. So if you have a sort of imaging platform, you directly also have a user base you could ask questions, and I think that's extremely important. So that's the idea. It's relatively modular, and also similar at the input you have things like PulseSec, so you don't need to, even if you change your console hardware, you can still use your pulse sequences. And then at the output you have open data formats like ESMRMB, and then you can plug it into your reconstruction pipeline, get it from BART or SERP or whatever you're using. So that's relatively flexible. Okay, so this is more to some technical details on what we're planning, what we've been doing, and probably more details that I don't have the time to talk about. But just coming back to this initial split that I made between this public domain science that we are currently in and our products privately, I think now we are, and we also don't know yet where we will end and how we can actually draw this line. So which parts can be publicly, I'm sure there are some things that will stay there, like independent scientific evaluation or clinical evaluation, for example. But other things, if we have open source repositories, but if we have a structure that is compatible with an MDR type regulatory process, design history files, etc. Yeah, where can it be positioned? The same with safety, quality. Maybe you will not have all the aspects from a certain regulatory body, but you will have a wide community that is actually testing these things and is continuously improving these things. Yeah, so that's quite interesting. We don't know yet where we will end, but it's definitely something that we are excited about to see. Yeah, how to make things more accessible and affordable. We also engaged that in a more simple level, and here's an open lab medtech, as we call it, that's we did within the hospital, and they are much simpler projects than an MRI project. And so maybe it's a very simple example that is on the right. You cannot see it because of the video, but glia.org. So it's a 3D printed stethoscope for a material cost of maybe €5, and there are some you can have some studies or clinical evaluation that it performs very similar to a very expensive design. Yeah, so these things are possible, and there are also, especially with 3D printing, there's some work ongoing to have also some regulatory pathways or easier regulatory pathways towards the clinic. So that's also something that's we started to talk more with clinical people. Okay, now coming back to the end and to my last slides and to actually this meeting here, so camera, and I just some bullet points that I would like to hopefully I could transmit it. So the way we approach it is that one group cannot have the funding capabilities to pull this off. It only can happen in a wider group. But in a sum, we do have a lot of resources. We just need to somehow find a way to communicate and to use this in an efficient way. All these resources that we invest in an open source approach will end up in the public domain, which is nice. It's decentralized, it's sustainable long-term development, which is nice. We have fully transparent systems, construction, maintenance, evaluation, innovation, education. There are many opportunities. We have much lower investments needed than for a company to produce products. So hopefully this will be or translate to more local businesses and more competition on the market, which is good. This will lower the prices. We will close this gap between science and products. Device safety. To me personally, there's one device safety. There's a different way how to communicate it with different regulatory bodies. But we know the standards. We know if we comply with them, that we can make a device that is safe. So it's, when I talk about open source, it's not. We basically want to push it to a level that is not hackathon, quick soldering, no, but in a professional way. And then the devices are safe. Even if you don't have clear regulations, which is the case in many low resource settings, no? But you can still have very safe devices. It's open source the most efficient way to collaborate, customize, innovate. because it's simple. We can just talk about it right now without any NDAs, etc. Free global expertise, and it's, I said it already, it's connecting people. Yeah, so we have something where we can, outside of this meeting, are able to connect people, and we can create blueprints. So we start with local because it's possible with locally. It's relatively mild resources that we need to invest, but you still get a full MRI system. Just from the physics and from the electronics, going from 2 megahertz to 64 megahertz, in my opinion, it's not a big it's not a big deal. But we need to demonstrate at first that it works, and we're building the infrastructure. When we have that, of course, we need more industry collaboration, and this is what's needed, and it's also needed in a low research setting. So if you know someone that is interested to go this path along us, it would be fantastic, and it's needed. But it's also possible to do it with other systems. Yeah, so we can explore that. Yeah. So yeah, with that, I'd like to thank you very much. My time is over. Sorry, I'm 2 minutes late, and thanks.
Thank you very much. I will take over presenting this, so Marina can prepare the meeting, the slides from remote, because we have 2 speakers from remote now. We start with Christopher Adlung. He is a technical university in Delft in the Netherlands, where he investigates how telemedicine can support frugal innovation in low middle income countries, in several countries in Africa. And during his studies in Germany and the United States, he did several volunteer projects in these low resource settings that brought his interest to do this work. And he will give us a lecture about socioeconomic factors for adopting low-cost medical devices in low middle income countries. So welcome, Christopher, the floor is yours.
Thank you for the warm welcome, and also thank you for my predecessor. I have to admit that I'm very much familiar with the university in Leiden and also the frugal MRI scanner that they incorporate, and I'm very grateful for the segue that you contributed to, because what you have demonstrated is basically a product design and a development that is certainly worth distributing, and I would like to focus today towards that shift in the context. How can we actually focus on diffusion and adoption of those kind of devices that have been presented? Maybe just a quick introduction to me, and I keep it brief with the notion of time. I am not a clinician. I'm not a medical doctor in the field. I'm more or less the person who would like to investigate how medical devices can get distributed and adopted in low and middle income societies. As we all know, we all face great innovations and inventions, and at some point they go into a realm that disappear. And therefore, I would like to shed scientific light on that, how that helps. And I'll also give you a good example of why I'm doing this, because there is a origin story behind. So without further ado, let's dive into the discussion today. Before we talk about costs, I would like to emphasize one notion that has already been displayed here in the context of frugal innovation. I will dive into this in a second. My second part will focus on a paper that is coming up soon with regard to the economic factors that contribute towards the diffusion of medical technology. And last but not least, I would also give you a little bit of an insight into why this PhD track is of interest, also from a very practical standpoint, given a volunteer project that we're supporting in the beautiful country named Togo. So let's dive into frugal innovation. Keep in mind that many low resource settings obviously have completely different set of boundaries involved. And the denotation of frugal innovation refers to that boundary. Obviously speaking, we all have some form of constraints, but the set of constraints that we face in LMICs are a completely different one. So this overview gives you a kind of etymological origin from the term frugality, originally contributing to an enjoyment or prudent or fertility. And in that regard, I would like to connotate it. In some academic resources, you can also find a negative connotation for frugality. That's not the part that I'm addressing here. And I would more or less like to phrase it in a positive light, which brings up or acknowledges the fact that we have a different set of constraints in low and middle income countries. I think the term innovation is quite easy to explain, so I will skip over that. But in combination, this is an important notion that we have to incorporate in all of our design choices to make sure that adoption can be actually applied properly in LMIC settings. So when you look up the literature, you'll find various terms and definitions for it. Obviously, there is no clear frugal innovation theory out yet. Instead, there are many other famous diffusions and adoption theories that are existent. But what you can always see, and this is a kind of common denominator, you can always see a kind of product-oriented, a market-oriented, or a somehow criteria-oriented definition for frugal innovation. And in this particular context, I will further focus on the product side. So what kind of product design elements are inherent for a frugal design, and how can this be leveraged into a proper diffusion? To give you, and one has been already displayed, to give you a few examples of very successful frugal innovations, one being mentioned in the bottom right corner, just displayed in very detailed, the frugal MRI scanner displayed in Leiden. Maybe just a ballpark figure, and I'm sure you're all aware of this, the regular Tesla model that can be deployed from a CapEx standpoint is 1.5 million USD. If you deploy the frugal MRI scanner as existent today that we've seen, it's like 20,000 USD. And that means you will certainly have a cost advantage. And we have also seen there is somehow equivalent quality in place. But the question is, why doesn't it get diffused properly, and why doesn't it get to a broader scope? There are other examples. For instance, the MIDI-cool refrigerator that probably everyone is aware of when you think of frugal innovation. That is a phenomenon occurring in India. There was a gentleman, an engineer, who came up with a refrigerator that runs without electricity after an earthquake hit his village. And apparently this, based out of clay made refrigerator, keeps the fridge or keeps the food fresh for up to a week, but with costs less than $100 US. You could argue that $100 US in an Indian village is also something that is, from an economic standpoint, not affordable, but it is significantly more affordable than a regular refrigerator purchased as an import. Based on the time constraints, I would like to skip a few points, but keep in mind that frugal innovation is out there, and it is significant. It has significant importance when it comes to adoption in LMICs. Maybe one complete notion, or to give you a complete big picture of what frugal innovation means under the notion of constraints. It always refers to three elements. First of all, it has to address a certain market, and it needs to be affordable for that market. The second one being, it needs to somehow face the resource constraints available. Like I said in the example with the Indian gentleman who invented the fridge, obviously there was no electricity running, and based on that scarcity, he created something. And third, what you also find mostly in LMICs, at least from a transparency standpoint, is an institutional void, meaning that you sometimes have a corrupt government not taking care of it, or you have lacking bureaucracy processes in place. Then you have insufficient aid coming from outside, and all these things create an institutional void that you have to cope with in order to diffuse technology properly. And to also give you a broader picture on where you can think frugal innovation in the context of like economy and recycling and circular economy, this picture gives you an overview where you can say, in a traditional linear economy in which you have to take, make, use, and waste products, elements, any kind of ingredient, frugal innovation takes the overall layer from recycling to circular economy taking the notion into account that you also take from the ground what you only require because that's the only thing you have available, and give back to that. And this is a quite, let's say, a broad impact that frugal innovation can have in LMICs, but also, and then we get, you know, a different term out, reverse innovation, but also in the developed countries. So I would also like to be an advocate in that sense to say, yes, we have to incorporate frugal innovation from a systemic standpoint for LMICs, but please keep in mind that resources are short and they're getting shorter. So in the context of SDG 3 and all sustainability contexts out there, we need to make sure that we also incorporate this notion in the Western societies. So without further ado, I would like to shift over to the research perspective. And I would like you to abstract from what we've heard in the first two speakers, because this is going to be a more systemic level. So I'm not looking into specific kind of products and developments rather than from a top-down perspective. So my personal interest in the research is about telemedicine. And I would like to see to some extent how telemedicine can support the adoption and diffusion of frugal innovation. Ironically speaking, or maybe this is serendipity, one of the identified frugal innovations is obviously the frugal MRI scanner that we've just heard about. And in that context, one of the constraints that we had to face, or when I talked to the gentlemen from the creators team, was the immobility of the device. We've seen nice pictures with cars, but what if you really need to have a kind of medical expertise on site that you can't? So telemedicine can bridge this gap, and the question is, can it support it properly in the context also for adoption and diffusion? And in order to get there, there's a lineup of different articles. And in this particular presentation today, I would like to focus on the very first one on the left-hand side, in which I will look at certain factors, adoption factors, in the context of medical device equipment for low resource settings. And in this particular part, I'm not particularly looking only into adoption factors, but also in the frameworks that exist in academia. So the status quo, as we know now, is that health technologies, they are essential for the functioning of a health system. We need that. And the health technologies can be classified as core functions of that system. The question and the challenge that we face, however, is that in low and middle income countries, the availability, the supply, and the access in all its facets is highly limited. So how do we overcome these barriers? Well, there are guidelines, there are models, and there are framework to do so from various angles, starting with the WHO. But what is an appropriate framework from a contextualized basis to actually do this, independent of maybe even the technology itself, but also appropriate for other settings? So, and therefore, I would like in this article at least to demonstrate a gap in the literature in which we look into all kinds of frameworks, models, and guidelines to bring together the best out of each framework in a certain setting to make sure that we understand properly the diffusion from the beginning, so we can also build that into the design and into the technology that we're creating. One famous one in the literature that you will always find is from Leonard, the cause-effect diagram of health innovation implementation. It gives you all kinds of resources and elements available. It also gives you kind of success factors for innovation implementation. So one of the key elements that we are running in our department for TPM Health, TPM stands for Technology Policy Management at the TU in Delft, is to say, let's also innovate something or utilize something that's already existed and test it out in the field for diffusion. And this framework could be one of them. And I'm in talks with a couple of people to actually use that for telemedicine. That's one implementation piece, but also for the existing frugal MRI scanner, so we can have a better understanding how to diffuse the technology properly. We are, from a methodology standpoint, we're building this with the notation of, we always look into models, we always look into guidelines and frameworks. I will agnostically, or I will definitely not look into any kind of design stages, rather than we do all kinds of design stages right from the beginning. And we also incorporate all kinds of medical device and equipments to make sure that this framework that we are looking at, or all frameworks available, are mostly encompassing. The only thing we will exclude is how specific the technology is implemented. And we're not looking into pharma because that's not the point, but we're building it as a systematic literature review and a Prisma-based design. Currently, there are 2 databases in screening or have been screened, but I'm also looking into extension of that. So to give you a glimpse and also a kind of notion about what this framework could look like, the first outcome is we have a set of underpinning frameworks that have been used in the literature, mostly known for the Rogers diffusion of innovation or the UTAUT framework or the technology acceptance model. But those are the underpinning frameworks that inspire all researchers in their contexts and applications. But what is more interesting is how they have been applied this to their own product or development and how that shaped out. And what can we learn from that to make sure that we not only acknowledge the existing of the framework, but we also critically reflect whether or not this framework is appropriate for this use case, context, product, and market. And the second outcome, which I think is more interesting in the long run, is I'm also looking in every aspect what kind of adoption factors are inherent in these frameworks. Let it be a self-developed one, let it be something like a classic and very well-notated framework like the diffusion, Rogers diffusion framework, but let's look into every single aspect of adoption and highly, like let's say bottom or top-down speaking, highly generated, we look into economic, technological, organizational, political, and social dimensions with respective indicators to make sure that in combination of each of those technologies and devices available, there is a mixture, a configuration to be found for the specific context. Call it product market fit, call it product culture fit. It doesn't really matter. What is important that you find this configuration so you can deploy it properly in the market. So what are the next steps? Right now, we're still in identification of the gaps from existing frameworks, even though we have 35 plus analyzed. We still lack of an in-depth analysis for existing use cases, even though there is a nice map out there that we can talk to. But what is also interesting is how can we utilize the identified adoption factors, over 800 I have on my list now, that can be applied in the context for various forms. Maybe we can use it for surveys, maybe for focus groups, for interviews. We will see. But the point is that we are utilizing not only the, let's say, the body in terms of the frameworks, but also the really much like granular elements that contribute towards adoption and diffusion. To give a little bit of acknowledgement, this is not only my work, but also the work of a couple of very bright minds, one being Saba Hilrich-Krappels. She's my supervisor for my PhD, also known as, also to be known Caroline Figuera, and JC Deal, Jan-Karel Deal, all very bright minds coming from different perspectives, from a medical, from a systems, and from also a design standpoint, which makes this very much interdisciplinary and interculturally and a phenomenal work, I think. So in addition to what I have displayed about the diffusion piece, I would also like to give you an insight into why I'm researching in this field and why I think this is also an aspect of why this should be implemented to a very pragmatic standpoint. So in the beginning, when I was on my journey for the PhD, I was actually consulting the government in Togo, in Lomé, for a conceptual design for telemedicine. And unfortunately, this was part of a volunteer project, but unfortunately, this didn't lead to a fruitful outcome. And at some point, even though we had successful discussions, the regulation said we can't do it. So The conglomerate that I was representing at the time, we were not happy about that decision, and I volunteered to say, let's put some scientific light to this. Why something like an existing technologies in neighboring countries, in Nigeria, in Benin, in Kenya, and Uganda, doesn't really get to a country like Togo, even though Togo has a huge demand for telemedicine. Just to give you two numbers, the amount of physicians available for 1,000 people is 0.08. In relation to a European average, you can think of 24 for 1,000 people. And also what is striking is the fact that 60% of the population in Togo is under the age of 25, and even 40% is under the age of 15 years old. And most of these people obviously live in the outside of the capital in Lomé. So you have 8.5 million individuals, and 2 million live only in the capital. More than 6 million people live actually outside the capital in rural areas without good access in various forms to healthcare. So telemedicine would be a very good approach. So what we're aiming for is, in combination with government support, diplomatic support from Germany, but also from Lomé, we are aiming to build a medical center that combines the notion of sport, education, and medicine at the lake Togo-Kome, which is roughly 1.5 hours east of the capital Lomé. There is a beautiful lake, and we implement rowing as a sport and also as a kind of gathering for the people on site. And as of today, this is actually very cool news. As of today, I can happily announce that the World Rowing Organization is actually spending 1 boat for 8 people and 3 boats for 2 people to donate this.
Christopher, apologies, but we have 1
out?
minute left for you. Yeah,
okay.
You're really running out of time.
Then I'll
Lucia
wrap it
has
up. The point is,
okay,
and I'm happy to send you the slides, the point is that we always have to notate the fact that when we do research, we should do it on our desktops, but at some point we should bring it to life and also to the people we need. And that's why I'm a huge advocate for doing implementation research between the low and middle income countries and the high income countries. Thank you.
Thank you very much, Christopher. In the interest of time, I will proceed with the presentation of Lucy. Lucy, are you able to give your presentation? Because you have to catch a flight, or will you do that?
Yeah. Hello. Udina is on standby to help if I'm not able to finalize it. But I can just introduce it and maybe tell you who's working with us on this.
Yeah. In the meantime, Tina will try to open it, or are you able to? You have her slides, right? Yeah. Please go ahead, Lucy.
Yeah, sure. So I'll just introduce myself. My name is Lucy Kanya, and I'm an assistant professor at the London School of Economics. I'm working with a range of people who I wanted to just mention here. So there is Uduna, Dr. Uduna Nazo, who's an associate professor at Montreal, McGill University. Adekele Olusola, who's with King's College and with the NHS. Professor Jha, who's from the University of Penn. I'm not sure how many are attending today, but it's been really lovely just listening to the rest of you. Everybody that has been speaking so far has been alluding to what we are doing and could contribute in many ways to what we are doing. And I must say that I'm also not a medical doctor. My background is in health economics and lots of experience of European countries. So okay, I'll just go on. Udina, maybe I think it's safer. It's a bit noisy now, getting a bit noisy where I am. But so I think best to just hand over to Udina. I'll stay on as much as I can and answer any questions that come along. Udina, I don't know if that's fine with you.
Sure. Can I have the slides loaded up? Because I don't have the slides here.
Okay. Thank you. Thank you very much, Udina. Thank you.
We're working on that.
Okay, thank you. I'll wait for the slides.
Desktop 2. The desktop 2, yes. Okay, yeah. Yeah, and then you can put the slide back. Nearly there. Now you should be able to see the slides, right? You do now?
Yeah, yeah, if you can put it in slideshow, that would be helpful. Okay, there we go. Fantastic. Okay, so thank you. This is actually Lucy's work, so I'm going to try to present it. I'm not a health economics. I think most of you know who I am. I'm a physicist. So let's just go to the next slide. The motivation of this work is more or less to really start to understand, and I'm glad that Lukas and Christoph has already gone to lay the foundation. But the main aim of this work is really to start to understand the return on investment when we start to introduce low cost, or even in what Lukas showed, open source, at this point, low field MRI. And so this work is essentially something we're trying to do in camera to start to address issues around investment and return on investment. Next slide, please. So I'm going to skip through this. We already know what the access issues are, and when it comes to MRI, and cost is one of the main concerns. And so I somehow lost. Okay. Oh yeah, there we go. And cost is obviously one of the main factors. There is a lot of effort now within Africa, at least in Kenya, for example, where the government is really doing a lot within public health. For example, introducing universal healthcare, and also introducing partnership with vendors, for example, GE, to enable clinics or even academic centers to acquire MRI at a reasonable cost. However, obviously, there's still issues with cost, and as we're moving towards introducing commercial and even open source low field equipment or low cost equipment, we need to understand essentially what is the benefit of starting to invest in some of these devices. Next slide, please. Okay, yeah, so and here Lucy is just trying to use sort of an example of what we know so far. And in this case, we're trying to use portable MRI and being very specific to the hyperfine system. We need data to start to understand what the systems can do. The hyperfine system, for example, is a brain-only, not a brain, but have been demonstrated in brain imaging, in imaging hydrocephalus, and also in imaging stroke. The data on stroke is very compelling. It does indicate, at least from the Yale group and the work they've done, that there is some clinical use of this where we can see 80% sensitivity in detecting intracerebral hemorrhage. And it also seems to demonstrate high specificity in identifying blood negative cases. But this is just one study, and obviously there's still more data. But this study actually allows us to start to understand and even start to put together a model of what could be sort of used to understand the economic value of sort of introducing the systems into clinical practice. Next slide, please. So the objective of this work, as I stated, is to understand the cost effectiveness. First is to actually develop a model to understand the cost effectiveness, and then use that model to demonstrate the potential impact of using low cost portable MRI units in low middle income countries, especially in the presence of the current funding model that exists in low middle income countries. We will use stroke as a pathology of interest because there is now some data coming out of it, and hopefully within with the cost, or with the availability of these units, we will probably start to look at other use cases like cerebral malaria, road traffic accidents, hydrocephalus, and etc. We're going to do a lot of this work within the Nigerian context, and that means using economic models, GDP, population numbers, and the plan is to start with that and then obviously translate this to other settings, first like Kenya and other parts. Our perspective is to fully explore the paying system or the provider mechanism that exists within this context. Nigeria, for example, most funding is self-funded, so people come and pay out of pocket to access MRI services. And that's obviously quite different from what I said earlier about Kenya, which is now having a universal healthcare system. And so we would like to essentially be able to incorporate all the funding perspectives. So our main research question is essentially very simple, is portable MRI, especially low field portable MRI systems, based on screening, more cost effective than no screening, because that's the reference. If you don't have an MRI scanner, you will not be able to have access to stroke. For example, what Christophe talked about in Togo. So the research question is portable MRI, can it be, when it's introduced, can it provide more cost effectiveness than no access to MRI, and also more cost effectiveness than within a stroke context. Next slide. And sorry, I saw the slides last night for just a brief moment, so bear with me. And so what we've done, first of all, is actually understand the stroke burden within the population that we'll be using. And in this case, we're going to start with Nigeria. So what's the stroke burden in Nigeria? I'm not going to go through a lot of this because of time, but we can see that ischemic stroke is quite prevalent, and the mortality rates in ischemic stroke is quite high compared to UK as a reference population. We also see the intracerebral hemorrhage, which is what low field, in this particular case, specifically the hyperfine system, has demonstrated its utility. We see that there is obviously the need to introduce MRI within, at least within Nigeria, to address intracerebral stroke. Next slide, please. While we're on this slide, one thing I want to highlight is that there is a the data obviously is very sparse, but there is a systematic review that kind of looked at the cost implications of stroke care in Nigeria. And the direct medical cost of stroke care was $8,000 in Nigeria. That's quite high, so there is obviously the need to try to sort of address this by introducing low-cost devices like the portable MRI system. Next slide, please. Okay, so this is where I'm going to have to skim through this because I'm not an economics, but this is Lucy's work. The idea here is to actually understand how what methods we're going to use to start to model the cost effectiveness, so more or less the return on investment. You have to be able to set up model where there is a reference, a reference cost or a known cost, and a known return, for lack of a better word. So the question is, what is the cost of treating everybody that has stroke, ischemic stroke, and received thrombolysis? What is the cost? What is the and the cost also includes, when you treat them all, the cost of care, the cost of post care, and the cost of loss of work during care, because that's also a cost that goes back to the society. So what's the cost and benefit of treating them all? What's the cost and benefit of treating nobody who receives thrombolysis? And what is the cost of treating and testing? So that's a model we're going to use to try to start to determine the return on investment when we use low field MRIs to treat ischemic stroke. Next slide, please. And so we have to have a metric for understanding what I mean by return on investment. So what do the society gain when, for example, we treat people with stroke? If we treat everybody, we treat some, we treat and test. Is it the quality of life? Is there an improvement in quality of life? Is there an improvement in, or is there a decrease in mortality? Is there a decrease in morbidity? And so we have data in terms of the quality of life for stroke from Nigeria, and we're going to incorporate that and use that as a threshold, as a metric of being able to estimate now what's the return on investment, what is the improvement in the quality of life when we introduce low field MRI systems specifically for treatment of stroke. And we have to do this in consideration of the investment. And in this case, like I mentioned in Nigeria, most of the cost of care, the burden is on the individual, on the actual patient. And so we have to also include what is the patient's capacity to pay for that cost. That means that do they have extra income? Do they have disposable income because there's no insurance and there's no universal healthcare system? Now, this will look different when we introduce countries that have universal healthcare system, even if it's limited, like Kenya, for example. Then when we do this cost analysis, obviously it will look different because we have different threshold values. Next slide. So I'm not going to dwell too much on this, but there are obviously local factors. Christoph talked about this, about social factors. There are local factors, local nuances, medical expense, access to that device. Obviously, we're not going to, it's not quite feasible, maybe it is, to start to put a lot of these portable systems everywhere. So there's still going to be issues with limited access or access. There's still going to be issues with income loss due to, again, delayed care, delayed treatment, income loss just by the nature of the disease. And there's obviously family impact that we also have to consider, because that's all costs, societal cost. Next slide. And then other factors include role of imaging. Is there a clear pathway to introduce or incorporate low field industrial care? There are training and other factors that have to be considered so that when you introduce portable low field MRI systems, you're able to introduce it where it doesn't affect the care pathway negatively. What are the benefits of the actual MRI infrastructure in terms of investment? Is it going to essentially lead to or reduce brain drain, meaning a lot of doctors are leaving because they don't have actually the infrastructure to work? With introducing this, also reduce brain drain, which also ends up putting back money into the society, into the community. So we will consider all of these local nuances when we're trying to develop this model. Next slide, please. Let's see here, access shapes. Oh yeah, so I guess the essence of doing this work is when we talk about accessibility, oftentimes talk about just the presence of that particular care. So having physical access to an MRI scanner, being able to stick your head in the scanner and get a scan, but access goes beyond that. And in high income countries, where MRI facilities are quite conveniently accessible in terms of even just being able to get on a good paved road and get there, where there's funding either through universal healthcare system or insurance, being able to address and develop models that can allow us to even incorporate accessibility measures will actually allow us to be able to develop much better, health economics model to understand the cost effectiveness of low field MRI. There's obviously challenges that we will not be able to address within this model because it's obviously not encompassing, but it's actually a start. And some of those challenges may be limited and different and look different in different settings. Next slide, please. There's obviously cultural resilience, which is very unique. I shouldn't say very unique. It's something that we have to bear in mind and understand, especially when we're working within resource-limited settings that tend to be very resilient. How we model that, how we include that is still something that we are thinking about, but it's something that is worth including in the model. Potential of MRI facilities. I don't understand what she means there. All right, well, I think we'll skip that slide. I'm not sure if I understand that. Next slide, please. So I think just to wrap up here, the aim of doing this work is when we're introducing these low-cost devices, we need to start to understand, especially in resource-limited settings where obviously there's a need for it, we need to start to understand if this is a good investment and how that actually benefits the society from an economic perspective. Next slide. Next slide.
It's the last slide.
Is the last slide? Okay, okay, thank you.
Do you understand this slide?
Yes. Okay, so I think that's the last slide. And again, this is essentially Lucy's work. I'm not sure if I did it a good service or if I did it a disservice, but essentially the aim of what Lucy is trying to do is to essentially help and plug in some of the gaps that Lucas talked about, that that private side, where oftentimes we as physicists, or even people that are building some of these very useful portable systems, this is one gap where we need to fully understand if the systems actually are beneficial to the society in terms of it won't be added cost to them to acquire it. And I'm going to end here, and I will try to take questions, and if I don't know them, I'll channel them back to Lucy. Thank you.
Great, well, thank you very much. Thank you very much for all the speakers. We're starting the panel discussion now, so I would like you to come forward. And then Lucy 2.0, Yuduna, I hope you stay online, and Christopher as well, so you can take any questions. I have to say it was indeed very economic, so I'm not sure how many physicists here will ask economic questions, but I'll open it to the floor first. Does anybody have a question for the physical virtual panel? Rick, you want to come forward and ask your question, please?
It's actually a remark and a question at the same time.
Yeah, you have to. Rick, if you stand here, the owl can also hear your question and relate.
Yuduna, can you hear me?
Yes, I can. Thank you very much. Nice to see you, Rick. Lucas as well.
It's interesting. Many things came as a subject to these talks, especially for Togo. I have some numbers. I have heard some numbers from Nigeria. Personally, I am involved in training radiologists and neurologists in Rwanda. It's the same situation. So what I think there, they wanted me to train them for stroke imaging, and because the neurologists wanted to understand this. There is people. You have 6. How do you? What kind of a pathway should be taken? Should we do this all together, train people, and then also install the system at the same time? Should we also involve them if we develop systems? Because I hear people develop systems and so on and so on. But are you working together with these people to have them understand how it works and so on and so on? Because I think it can only be sustainable if it comes from them. We should give them the power to organize their own work, because there's many cultural differences. There's many obstacles that we do not understand from our side here. At least I learned some, and I don't know everything. But I don't know what your ideas is about these things.
Hello.
Is it on this microphone?
Yeah. Can you hear me? Yeah. Awesome. It's a great point, and I think we are still at the stage where we are assembling a robust system. So it's still very much or more the focus on technology. So we are nearly there to get them involved, but we are not there yet. I would say it's too early yet. I think once we have a stable system, and then in particular the software for it, I think this will be the stage where we need to go closer to the users. But just from a personal feeling, others might disagree.
Yeah.
Would the telemedicine help there?
Well, telemedicine is usually a very expensive service that is being used in this country and in other countries in Europe and the States. I don't know how you have to go and set it up locally there. It's a great idea, but if you have only 6 radiologists and 4 in training, and you want to put the MR system in the district cities, for example, in Rwanda, you will probably not have enough people.
The owl has an answer. Christopher would
yes.
like to.
No, I have an attempt. I don't have a clear answer, but maybe a recommendation. I mean, first of all, when you consult the literature, there are various answers to the degree that you would have to have a 30-60 degree and ask pretty much every stakeholder, not just the patients and not just the hospital and the local capacity, but also maybe even the vendors. there is a nice paper I'm happy to distribute that addresses that notion, saying that you can implement or try to implement any kind of technology, but the existing incumbents and the vendors, they have the power structures in place to prohibit any kind of innovation that you might bring in. For instance, with the frugal MRI scanner, the experience that we had in Togo, and this is a 5-year journey now, is even the politicians doing like a good job in the sense that they want to do good for their voters mostly. But then you have insurance companies who have a completely different incentive structure. And again, the point is that you may have not encountered that as a stakeholder.
So we were losing you. Can you repeat your last sentence?
Excuse me, yeah. I'm saying that you may have.
We were losing you for a second.
Sure. You may have not encountered all stakeholders in depth properly, for instance, insurance companies or vendors supplying the medical equipment. And then you ultimately run into conflicts, and then you end up in innovation of death, so to speak. Thank you.
Anybody else want to comment to that? Yeah, can you come forward, please? And yeah, there's also one on the chat, but we'll.
Yeah, my question is actually for you, because you wrote the study. I think your name was as the.
Can you come a bit closer so the owl can hear as well?
Oh, okay. Oh, sorry. So how difficult was it for you to get the data? Because I mean, it's not accessible easily. I mean, as long as I know. And did you have to go through the UN website, or did you actually have local people that helped you with that? Or yeah, so that would be.
Yeah, so sorry. That was a good question. I don't know if this is on. But yeah, so a lot of the data, we did rely on a lot of information from the World Health Organization, as well as like UN information available. But thankfully, we've got close links to individuals working in those regions, and like with the camera network, so we're able to pile and use their data to like.
Sorry, at the back, can you turn this microphone on, please?
Hello?
The other.
Yeah, it's working. I'm just not working. Hello? Hello? Yeah. I'll start over. Essentially, we had to use data from the World Health Organization, but we also used a lot of what was available on websites such as PubMed, MedMBase, and as well as using our connections with the local authorities and people working in those regions. So Camera was great because they've already got a lot of data from working with a lot of the hospitals and radiographers and radiologists in this region. So that was one way we put together the data. But you're right, it is quite difficult to actually get that information unless you're actually physically there on site. So yeah.
Is it working? Yeah, it's working. Okay. I actually have one comment to Luna's talk or Lucy's slides. So you showed so you're doing the study, economic study on using the hyperfine system as a basis, right? This has and you showed that the price, I think, we ranged it in some 50 to 150,000 US dollars. Just a comment. So this is a price that most probably an open source system will have, but the hyperfine system is definitely more expensive than that. So the purchasing price was maybe in the beginning somewhere around 50,000, but you cannot use the system without a service contract, which is actually quite expensive. So if you sum up all these costs over a period of 10 years or so, so let's say the hyperfine system is more of a 100K a year scanner. Yeah, it's not a cheap system. So my suggestion would be take your data, leave it to 50 to 150,000, and then convince local authorities to invest the difference that you would buy your hyperfine systems, invest it in actually making a local business and distributing open source MR scanners. And I think you have local jobs, you have the technology knowledge, education, etc. I think this would be a much better way to go.
No, I do agree with you, Lucas, and
anybody
that's
want to comment on that?
yeah. Let me just. It will be a 2-second comment. So yeah. I do agree with you. Hank, am I muted? No. Okay. I do agree with you, Lucas. This is actually what we are starting to look into and trying to redefine the return on investment beyond just money to include exactly what you said, putting back jobs into the local. And I think I talked about that in terms of brain drain, but that's not just brain drain. It's also being able to figure out ways to reinvest once you're able to bring down the cost. Bringing down the cost would be going from, instead of buying a full 1.5T system, to buying a low field system. And even I like the idea that you brought about even bringing down the cost by looking at open source options. So yes, we are thinking about that. And that's some of the, well, I say, social cultural factors that are not typically modeled when you look at other health economics models out there. They were trying to sort of redesign and remodel. Yeah, so I hope that sort of answers your question, but yes, we're looking into that. Thanks.
We're nearing the end of this session, but I would like to give Jonas the opportunity. If I mention your name correctly, Jonas, could you please, you would like to ask a question?
Yes, please. I don't know if I am audible.
Yeah, we can hear you.
Okay, thank you. Yeah, thank you for the great talks. Starting with Lukas, I am a big beneficiary of the open source imaging and the tools that come with it. One of the questions I wanted to ask is that much as on this side, I am assuming I'm getting things for free, but there's somebody paying for them somewhere. Lukas and his colleagues are probably spending a fortune to develop all these tools and designs and everything to make them free for people like me. So my question is there any business model around this open source imaging? Because in the end, somebody has to pay the cost. It might not be me. I could be receiving it for free, but somebody is heavily subsidizing that cost or even paying for it. So is there any sustainability models for the open source? And then maybe for who was the second speaker? If I would, Christopher, the frugal imaging, the frugal technology development, I think is a very great idea. My question is as it regards to health, because that is sort of my space. Like Uduna said, Kenya has universal health, and many of the low and middle income countries, the health sector is heavily government-based. People are expected to get treatment for free. The government buys drugs and equipment and everything. That is how it should be. However, it is not exactly like that. So many of the technologies that we develop locally are sometimes perceived as low quality products, and government is not expected to buy low quality products. So we get a challenge sometimes that it becomes very hard to penetrate the health sector market. In your social and social factors for adaptability, do you think there is any way around that kind of roadblock that we face? Thank you very much.
Christopher, you want to comment first, and then we go back to Lukas behind me.
Yes, Jones, thank you for the question, and I'm happy to meet you. We have always talked about each other, I guess, but now I have the chance to meet you here in the panel. So yes, there are social factors. In fact, we're addressing around 83 in our framework that we're currently building up. And obviously speaking, the notion that you brought up in the sense that this is low cost, yes, that's why I phrased...
Christopher, we are yeah,
You're
please.
lacking? Okay. Sorry. Okay. So we have quite a set of identifiers, let's say, that I'm happy to distribute, Jones. And I can estimate why you're asking in the context of the frugal MRI scanner. In general, it is highly context specific. And these factors need to be tested out in the field. That's why I would like to build up a kind of scientific background for that without blurring them out, so to speak. But again, the notion of something that is cheap is correct. That's why I emphasize the point that frugal innovation is not cheap, but it's easier to access. And as Uduna's, one of the paper Uduna's bringing out in terms of accessibility, accessibility for the cost factor, that is essential, and especially for the people who pay out of pocket because they don't have insurance. So maybe, Jones, we can take this a little bit more bilateral with Uduna at some point. I'm happy to support you with the social factors.
Sure. Thank you. Thank you.
So maybe Lukas can give the answer to who supports his open source work, and then we would have to close this meeting.
So who's paying for it? I will just give a quick answer. First of all, we are doing public research, and everything we're not sharing is somehow a waste of money. So we also do this research for us, right, for our healthcare. When we share this information, and you can use it, I think that's the most efficient way of turning the dollar into something useful. So the motivation is not only the motivation is for health, and there's one healthcare. Then I think I would revert the question: are we having an efficient healthcare system at the moment? So are we really turning in the most efficient way the investments we are creating into a product, or is there too much overhead? And I would argue that there is too much overhead. So we're actually having a lot of waste of money at the moment. Yeah, so I think this can be done in a more efficient way. And then, of course, I mean, for us, we are able to generate this information. Once you have your system and you can do imaging, you will contribute. It will feed back into our system and our knowledge. And this is how it's being done at the moment in the research society and let's say higher research things. Yeah. So we just want to get you also on the table, and this only works. We invest a bit more, but at some point you hopefully catch up. So that's great.
Yeah. I think we had a lot of conversations on aspects of imaging equity that often get ignored. Please join me one more time as we thank our speakers and my co-chair. We wish to continue this journey with the ESMRMB, and I would also like to take this opportunity to thank our sponsors, including the Chan Zuckerberg Initiative and the Lacuna Fund, as well as our vendor partners and our volunteers. Again, please reach out to me or visit our website, camera-mriafrica.org, to learn how we can work together. So thank you and enjoy the rest of the conference.
Thank you, guys.
Thank you.
Bye-bye, everyone.
Thank you, guys, for 22 participants.
Thank you. See you.
Very nice. Bye-bye.
Thank you, Christopher. See you.
Likewise. Thank you. Bye.
Yeah.
Yeah.